session. So we will be presenting a journal club article from the famous JAMA, Journal of American Medical Association. The topic chosen, the article chosen is a very relevant topic in our day-to-day practice, which deals with feeding of ELBW babies. So it is basically a RCT which compares an head-to-head intervention between feeding preterm formula versus pasteurized donor human milk with fortification whenever mother's milk is unavailable or when it is available in a very limited quantity. So it's very interesting. We'll try to start the discussion, and we'll again at the end we'll have a discussion with regards to the conclusion of the study. Ishita, can you start?
Yes, sir.
Thanks.
Good evening, everyone. I'm Dr. Ishita Singh, DM resident at Srihar Institute in Chennai. And today's topic for discussion will be the Journal Club Milk Trial, Neurodevelopmental Outcomes of Extremely Preterm Infants, Fed Donor Milk or Preterm Infant Formula, Randomized Control Trial. This article was published quite recently, Jan 2024 in JAMA. And as we all know, JAMA is one of the highest rated journals with the impact factor being 120.7. So my presentation will be going through the following headings, discussing the background, the trial characteristics, the methodology, safety, results, and discussion, and the critical appraisal using the CASP checklist. So coming to the background, we all know that extreme preterm infants are forever at risk of neurodevelopmental impairment because of multiple factors, and interventions in the early stages of life should be targeted to improve the outcomes as needed. And feeding forms a very, very important vital role of that part. And of course, mother's milk intake has been consistently associated with decreased risk of all the important outcomes, and there is no discussion whether there is any modality better than that. However, coming to whether comparing mother's milk with any other diet on a pure RCT, depriving the other population would be quite unethical. So there have been a number of studies which have been attempted over the past 2 decades, not even 2, in fact, even 3 decades. Researchers have been trying to understand various combinations of donor milk versus term formula milk, donor milk versus preterm formula milk, and then supplemental donor milk along with some baseline of mother's milk, just to understand as to which intervention would be least harmful to these vulnerable infants. Pasture donor human milk has recently become recommended as the preferred diet when mother's milk is unavailable, owing to the landmark paper 2022 published by Esfagan. And there is still limited evidence on the developmental effects of all the donor milks compared with infant formula. So given the observed benefits of maternal milk already, this RCT would probably encourage the use of PDHM milk instead of formula whenever mother's milk is unavailable, and can be taken as the take-home point, what they hypothesized. So the hypothesis was that use of donor milk compared with formula in extremely preterm infants who receive no or minimal maternal milk during hospitalization would result in better neurodevelopmental outcomes. So use of donor milk, the research question was use of donor milk would result in better developmental outcomes as assessed at the age of 20 to 26 months by BSID 3rd edition. Objective was to determine whether if nutrient fortified donor milk would improve the same outcomes. So this trial was registered by CTRI. The identify number was provided. The funding was given by the grants from the Eunice Carey Shriver NICHD. And the grants also were given from National Center for Advanced Translational Research Sciences. Population taken was the preterms less than 29 weeks gestation or with a birth weight of less than 1,000 grams with the chronological age from birth till 21 days of age. The intervention was preterm formula milk, and the comparison was donor milk, and outcome assessed was new disability. The trial was conducted from September 2012 to 2019. It was a quite long time for enrollment. The reasons, the issues they faced will be discussed subsequently. It was a double-blinded randomized clinical trial conducted across 15 academic medical centers within the Eunice Kennedy Shriver NICHD network. And they recruited infants less than 9 weeks from the ages provided from birth till 21 days of age. So the pre-specified safety outcomes were already established, being NEC, which we all know is the most common adverse effect faced with donor milk, intestinal perforation, culture-proven late-on sepsis or meningitis, hospital-acquired viral infections, death after randomization. And there were interim analysis also planned at 25, 50, and 75% of the enrollment when it was reached. And Pocock bounds were used to construct the stopping rules for safety. Just a little bit about what is Pocock boundaries. There actually is a method for determining whether to stop a clinical trial prematurely. So once the interim analysis is conducted, it gives a p-value threshold for each analysis, which guides the committee on whether to stop the trial. If the results are overwhelmingly positive, and similarly, if the two analysis of suppose the 5 have been planned shows that, then the decision could be made to prematurely stop the trial. However, the number of analysis must be fixed at the outset itself. And we cannot keep adding more analysis once the trial has started. Suppose the analysis are showing a negative outcome, and we still want to conduct a few more analysis, but that is not recommended. So if 5 analyses are planned, the trial is stopped at third analysis, which is showing less the significant p-value. Even then, the value of the total p-value will be given less than 0.005 and not as 0.001. So the inclusion criteria they're given was infants less than 29 weeks gestation, who were with the birth of less than 1,000 grams, who admitted to the centers before 7 days of age, but were followed up till 21 days of age. And if the mother's infant, the birthing parent, never initiated lactation, this could be applicable in suppose perhaps surrogate mothers, because the birthing parent was separated and probably never initiated lactation itself. To us, it sounds like a very rare possibility, but that could have been one inclusion criteria. Secondly, when lactation was initiated, but mother ceased expressing milk for 21 days, or suppose the milk supply was quite minimal, which is documented to be less than 3 ounces per day, whereas 1 ounce is around 30 ml. That means around 90 ml per day, consequently seen over 5 days. These two situations are seen somewhat frequently in our NICUs also. We do have mothers who will be producing good milk in the initial 1-2 weeks, but suddenly by third week, the supply decreases or becomes almost nil for various reasons. And they were randomized anytime from birth to 21 days if this criteria was met. Exclusion criteria given were chromosomal anomalies, congenital heart diseases, disorders known to affect feeding, and intrauterine infections, prior NEC, or any spontaneous intestinal perforation or terminal illnesses. So infants in the no maternal group were received basically a steady diet for all the feedings from randomization to hospital discharge. These are infants who truly received no mother's milk for whatever possible reasons, randomized to till discharge, death, or 120 days, whichever occurred earliest. And the infants in the minimal group received any minimal maternal milk available and the study diet randomized. So, of course, because it's unethical to deprive any infant of whatever amount of mother's milk is available. So, many infants did get some amount of mother's milk, but the quantity or how much of it has not been specified. They was just labeled as any or none. This is a study flow diagram, out of which 8,000 infants were assessed for eligibility, out of which ultimately 483 were randomized. The reasons for exclusion have been given. So finally, 239 were randomized to receiving donor milk and 244 randomized to receiving preterm formula. The loss to follow-up also has been described, and also the lack of achieving the intervention as randomized also has been described. Finally, for the primary outcome analysis, which was new disability 22 months of age, 206 and 217 were assessed respectively. 29 babies died in the donor milk group, whereas 25 died in the randomized group. And they have described that all the babies who died were given a standard score of 54 on the BSID scale 3. So ultimately, 177 and 192 completed follow-up assessment. There are types of feeding and supplements. So the donor milk was obtained from the Human Milk Banking Association of North America, and the preterm infant formula was as per standard practice of each institute that has not been disclosed. It was, so we're assuming it was not one standard brand across all the institutes. And the fortifiers also, they have labeled it as a bovine human milk fortifier, but which brand has not been disclosed. And the human milk based fortifiers were not used consistently. So the standardizations were preterm formulas, but which brand we don't know, or donor human milk. And the feeding initiations and the advancement of the feedings was not standardized across the institutes. So the randomization actually stopped after 483 infants due to a declining enrollment process and loss of equipoise amongst participating centers. The reason for this was because the increase and the boom in the PDHM supply after the ESPGHAN guidelines sort of endorsed the safety of PDHM as the second best option after mother's milk. So obviously, a lot of hospitals were able to procure and establish milk banks, and so naturally, the slow enrollment was because parents would probably be opting for a safer alternative, which is known as PDHM. That's why the trial randomization was somewhat stopped earlier. The protein content of the fortified donor milk also was estimated to be 2.03 grams per DL, whereas the unfortified milk was estimated to be 0.8 to 0.9. The timing content fortification and the initiation, as again, was the discretions of the clinicians. Feeds were prepared daily by the study staff, and 24-hour supplies was given to each infant bedside, and the infants were usually fed by the nurses or family members. Participants were assessed at finally 20 to 26 weeks of 26 months of age, and ultimately the infant cytometry were also weighed weekly, whereas length assessment was taken once in 2 weeks, and feeding tolerance was defined as withholding feeds for more than 24 hours, and receipt of any maternal milk was just assessed weekly. So the amber-tinned oral syringes and storage bottles were used to mask the appearance of the study diet, and the assessors were blinded to diet interventions, and the reliability of the assessors also was certified by the Neonatal Research Network and annually for the iterative availability. So primary outcomes assessed were cognitive scores on BSID, and infants who died between randomization to were those unable to complete were given a standard score of 54. Secondary outcomes were many: BSID language, BSID motor score, moderate or severe cerebral palsy, moderate or severe neurodevelopmental impairment, and they've given standardized mean score of 100 with the deviation of 15. Late onset subsets to be culture positive, NEC stage more than 2, death, and growth assessment as per plotted from Fenton's growth chart. Sample estimation, they assumed a mortality rate of 15% after randomization, and to achieve a follow-up of 90%, and a conservative estimate of standard deviation of 20 points of difference between BSID scores. It was estimated to get target sample size of 670, but only 502 were ultimately evaluated, would be evaluated. That should result in a 80% power to detect a 5-point difference in the BSI scores cognition. Enrollment was stopped as described after just 483. So of 670, they were able to only reach 483 infants. Analysis was adjusted for the birth weight stratum, the academic medical center, and age in days. Linear regressions were also used for continuous outcomes, and robust Poisson regression also was used to adjust between the group risk differences estimates. So planned subgroup analysis also were done. So the baseline characteristics of the study were comparable, with the gestational age mean being 26 weeks in both the populations, mean birth weight being 840. Showing female slight preponderance in the donor milk and male preponderance in the preterm formula. Along with that, they've also shown as a strength of a study the fact that this study has enrolled multiple geographic and multiple ethnic population across America, not just predominantly Caucasian population. So African American, white, other populations also were enrolled, and they've also included in the type of insurance and maternal education level. Why they have focused on it, they have discussed in the results. Then regarding the study diet, which forms the main stay of this study, the study diet intake, uh, the total duration also has been given along with the last age, last PME up till which the babies receive the study diet. So 36.6, the 6.7 for both the groups, which is comparable. The number of feed intolerances were significant, were 240 in the preterm formula and lesser in the donor milk formula. And any amount of maternal milk randomization after randomization again was somewhat comparable, but the exact quantity has not been discussed. Coming to us also having TPN along with that was the number of infants was also comparable for both the groups. So the anthropometrics as study entry and at hospital discharge were assessed along with growth during the study, out of which the ultimately the growth were almost comparable. The important primary outcome was that this BSID score, which after sensitivity analysis also showed a mean score of 85.1 versus 84.7, which was comparable and not significant. NEC risk, of course, was almost double in the preterm formula group as per donor milk, which is expected. The mortality also 18 versus 24, and other later onset sepsis outcomes and meningitis length of hospital stay also were given but not significant. So no difference in the given between the both groups in head circumference and length. The NEC, of course, was higher up, and no infants developed hospital acquired viral infections. So ultimately, the main difference also in the BSIDs after sensitivity analysis also was not significant. Coming to the discussion, because weight gain has always been postulated to be a bit better in preterm formula fed babies, but does this really will this help and translate into better neurodevelopmental outcome? Well, studies have shown that better weight gain does influence the incidence of CP and neurodevelopmental impairment, need for rehospitalization as another studies, but the weight gain was almost comparable in between both the groups in this study. Coming to the other donor milk trials, which out of which many have been conducted, many have also targeted the same population with similar interventions, looking at similar outcomes as early as 18 months to as late as 26 months and above than that also. The Domino trial in 2000 and 2012 was conducted with the same outcome, but the follow-up is still underway. Only the protocol is published. That also aims to look at the socioeconomic and the financial economic constraints of setting up a milk bank versus the alternative of safely giving preterm formula milk. Deborah et al. In 2016 also studied the similar outcomes, and they also found no significant differences in the Bailey cognitive composite scores, and neither in the mortality morbidity index. Willemijin et al. Also studied the similar intervention and outcomes. But they focused primarily on the more solid outcomes like NEC, mortality, sepsis, meningitis. But interestingly, their set did not show any different outcome in these serious meningitis or NEC. And also from 1980s to 70s, even now, multiple studies have been done. Many of them are still not able to show significant difference in the neurodevelopmental outcomes. But coming to the dose-dependent benefit of human milk also has been known. Even if many infants are getting some amount of mother's milk on top of their different study diets given as formula feed of PDHM, that also leads to lesser episodes of sepsis, NEC, and lesser episodes of meningitis. Then safety also has been safety of PDHM also has been studied significantly in quite a few studies, and that has been shown to be sufficiently safe. That is why it has also been endorsed by 2022 guidelines of ESPGHAN. And the Cochrane review by Kigley et al. In 2014, also which included 9 trials, out of which around 1,000 infants were evaluated fulfilling inclusion criteria, showed that formula feeding does increase the risk of NEC, but with respect to neurodevelopmental outcomes, the moderate grade evidence show that data does not show any effect on that same. So even the studies included in the Cochrane review starting from as early as 1977 till the later studies, they do show a bit of a slower growth for donor milk, but no neurodevelopmental outcome differences as such. But however, to come back to reiterate the fact that yes, breast milk is the best milk, and even 10 ml per kg per day increase in breast milk can improve neurodevelopmental outcomes and improve behavior percentile scores, and also risk of hospitalization is decreased. It has been shown consistently in multiple studies. So taking this fact into cognizance is important, again, because in this study, many infants did receive any amount of maternal milk, or even if it was less than 3 ounces per day, that is less than 90 ml. Even 10 ml per kg is significant, can contribute to a 0.5 increase in the Bailey score. So the impact has to always been taken into consideration, even while we're interpreting the results of such trials. So the limitations they have given are slow enrollment due to increased donor milk use at participating centers, and which led to the loss of equipoise. Initiation, less verified centers were using donor milk, so it was somewhat easier to achieve the enrollment process because PDHM was available with great difficulty. But by the time study ended, around more than 2/3 of the centers were widely using donor milk. So that would understandably lead to difficulties in enrollment. Again, the information of type and amount of milk prior to the enrollment was not collected. And also the nutrient content was not measured, and it could have been quite variable and quite different, because that has shown almost we would expect a higher weight gain in the formula fed infant, but that was not shown in this study. And they've mentioned the confounding factor of the mother's education, the type of public insurance policy, and the racial factors as having an effect on neurodevelopmental outcomes of the infants. And that is actually an interesting point they have raised, because after discharge and following up the baby still 2 years of age almost, the type of continuing healthcare the infants would have been exposed to, the level of healthcare, because in America, insurance types and levels do translate sometimes into the level of care you are provided. And not only to add to that, the level of mother's education also influence about of the stimulation and the early intervention that any infant will be liable to get. So they have postulated that the population may have been more vulnerable than the average preterm population, because there are higher rates of these mothers. If you look back at the baseline characteristics, the mean mother's age was also quite young. Their mean education was just about having achieved a high school diploma, not even having a college degree, and most of them having public insurance as opposed to private insurance. So these factors they have discussed as increased risk of neonatal morbidity and poor outcomes. Coming to the strengths of the study, to the best of their knowledge, this is the only largest randomized clinical trial of the donor milk versus preterm formula in extremely preterm infants undertaken in the era of the routine human milk fortification. And in addition, the study was also recruited from geographically diverse academic centers in the US. So they've concluded that among extremely preterm neonates fed minimal maternal milk, neurodevelopmental outcomes at 26 months of getted age did not differ between infants fed donor milk or preterm formula. So the hypothesis that use of donor milk compared with formula was disproved, and the research question was answered. So coming to the appraisal using CASP checklist, which is a critical appraisal skills program, which uses standard 11 questions to help us make sense of an RCT. Was the study clearly assessing a clearly focused research question? Yes. Was the assignment to randomized? Yes. Were all participants who entered the study accounted? They've given the exact breakup. Were the participants blind to the intervention they given? Yes, the patients and the parents were not aware. Were the investigators blind? In the study, they've mentioned at times that the feeds were prepared by the study staff, but the doctors also they were supplied in amber colored bottles and vials, so you would not know what is by looking grossly at the feed it is a donor milk or is it a formula feed. But however, once the infant age increased and was changed to a step 2 diet, the detail of which has not been available as supplementary data is not free, it's paid to access it. So the treating clinician might be aware of the diet which was the infant was randomized to at a later stage, not at the initial stage. So that's why the tick could be as can't tell exactly whether, and the people assessing were they blinded? Yes, so 2 levels of blinding were achieved. The study group similar at the start of the RCT? Yes. Apart from the experimental intervention, did each study group receive same level of care? Yes. And were the effects of intervention reported comprehensively? Yes. And the precision of the estimate of the effect reported? Yes. Do the benefits of the experimental outweigh the harms and costs? As of now, because the risk of NEC was quite significant in the donor, in the preterm formula fed infants. But ultimately, the benefits were also comparable. There was no group having a better developmental outcome, so it's difficult to say. Can the results be applied in your local population in context? It's difficult to say, actually. We can discuss that subsequently once the presentation is over. And would the experimental intervention provide greater value to the people in your care than any of the existing interventions? The answer would be yes. We can discuss in detail after the presentation is over. So thank you for the patient listening. I can now hand over to Rajan sir.
Thank you, Ishita, for your very elaborative presentation, which was also very lucid. So before opening the session for discussion, I will just try to highlight the main points of that study.
Okay.
So first thing is we should be very appreciative of this study because this is the largest RCT which is available till date, which has done a head-to-head comparison between PDHM and preterm donor milk, especially PDHM as a sole diet, not as an add-on to the mother's milk, as a sole diet, and comparing it with preterm formula whenever mother's milk is not available. So this is a very difficult study to be conducted, especially with growing evidence for donor milk. And I don't think whether in future similar large RCT will be able to be done because people are becoming more and more favorable towards PDHM and they know the dangers of preterm formula also. So I think whatever evidence, even Cochrane in the future may derive whatever weak quality or moderate quality evidence from this trial rather than conducting any separate trial. So this is a very big trial, so, and we have to appreciate them for this. Before concluding inferences from this trial, we should also know the issues regarding this trial.
Mm.
So the main problem, as you know, is the sample size was about 670. But finally, they were able to enroll only around 480 babies. They were almost short of 200 babies. So, as you know, as someone has also asked in the chat box, what is loss of equipoise? So, equipoise in RCT means when you start the study, you decide that you don't know which is better compared to both the interventions. That's why you are trying to do this study. But if you already know that one is better than the another, then you will always be biased towards that intervention. And obviously, that will affect the balance of the study. You will be more biased towards one intervention. So equipoise is basically a balance between two groups so that you are not biased towards any single intervention. Here, exactly what has happened is, as Ishita was telling, various recommendation bodies, including SPAN, started telling that PDHM is better and it's comparable to mother's milk, and you can use instead of mother's milk whenever it is not available, or you can add on to the mother's milk in the initial stages. And people already know that preterm formula has a very dangerous side effect of NEC. What happened is, as growing evidence for PDHM happened, when you started enrolling patients for RCT, when you explain these things to parents, obviously they decide that PDHM is better than formula. So they stop giving consent for enrollment in the study. That automatically starts affecting the enrollment of the study. So this is what exactly has happened in this study. And that's why they were short of 200 babies in the final enrollment. So this is what they refer to as loss of equipoise. Basically, equipoise is needed in RCT to have a balance between the two groups. But when it gets affected, when you feel that one is better than the another, obviously it affects the enrollment. So that is what is loss of equipoise in RCT. So that is the major disadvantages in this study also. So the other problem is, if you see here, the average age of enrollment is median age is around 16 days. So till 16 days, like what milk was fed to these babies. So that is not very clear. And obviously they would have given some donor milk or other mother's milk. So details of which is not, they have not collected the details of the following things. So obviously, as Ishita discussed, even a small quantity of mother's milk, if it's available for a particular period of time, that enhances the neurodevelopmental outcome of a preterm baby. So what if that particular baby had received up to 15 days a significant amount of donor milk or mother's milk? So that will definitely again affect the balance between the two groups. So this data is not available as a baseline characteristic to compare between the two groups. That again would have affected the comparison between two groups to finally produce any meaningful effect. And the third thing is, as you know, like once a baby receives mother's milk, the baby continues to receive the mother's milk exclusively for 6 months and beyond that. Same way here in this group, if we start preterm formula, the baby continues to receive that preterm formula for an extended period of time, 6 months, 1 year.
Right.
But when you go for PDHM, you know that PDHM is obviously availability is a very difficult process. It is also associated with cost issues. So basically, here also in this study, if you see, they have taken up to 120 days or almost like till discharge. So they have mentioned that 1 week prior to discharge, if they're going to terminate that baby from the trial, they will automatically switch over to preterm formula. So unlike the mother's milk and preterm formula, where they continue to receive it for a extended period of time, here they are cut shorting it to a particular period like 120 days or till discharge. So again, till that period only, the baby receives the benefits of PDHM and not beyond a continuous period of time like 6 months or 1 year. So again, it again affects the final outcome, neurodevelopmental outcome, when you try to see that at 22 to 26 months. So these are some of the issues which has affected mainly that enrollment, and why there was a 3-week delay period. That is basically a practical issue, but what did the baby receive till then, we don't know. And
Once the
babies are,
enrollment
yeah, yeah,
has decreased, and of course they were not able to reach the targeted sample number, then
yeah,
was the study truly continuous? Was it continued to be powered enough uh,
yeah.
to describe the
But we
outcome?
assumed
And
it's
is also another
we
question.
assume this much 670 babies that will have a 80% power to find at least 5-point difference in cognition between the two groups, but obviously they were short of that. So these were some of the difficulties they had faced that obviously affects the outcome of the study. And another important thing is, that in this study, they have, like many other previous studies, they have shown a clear benefit of PDHM over preterm formula, especially in terms of prevention of NEC. Even in this study, if you see, the NEC incidence is twice in those who receive formula milk compared to PDHM. This is a very well-known fact. And NEC is independently associated with poor neurodevelopmental outcome also. So that is one short outcome which has been again reinforced by this study. But in spite of this neurodevelopmental protection by means of prevention of NEC, why this study was unable to show a neurodevelopmental improvement between the donor milk group and preterm formula group. That again possibly because of all these issues like sample size and the initial milk intake.
They probably ended up getting a formula itself, then it was not continued long term.
So whether all these things started affecting the difference between the two groups, that finally you found that donor milk is not shown to have superior neurodevelopmental outcome compared to preterm formula. And again, another one more disadvantage is, even though we try to fortify, we don't know exactly what is the nutritional value of PDHM. We are just assuming that this powder, when you add, it gives 3 grams of protein. But you know that all these PDHM are being pasteurized. Pasteurization itself affects the nutritional quality of the milk. So finally, if you have to tell that this is not showing any improvement, you should actually know the exact nutrition value, because mother's milk means 100 ml gives this much value, this much calories, proteins. Same way, formula of milk, it is written in the tin that 100 ml gives this much calories and protein. But unfortunately, when we give PDHM, even though we do fortification and other things, we finally don't measure what is the nutritional value of the PDHM. So this may be another fact that may affect the difference between the two groups, so that you are not actually seeing any neurodevelopmental favorable outcome towards PDHM. So finally, because of these things, we are not able to conclude clearly that whether PDHM will have a neurodevelopmental favorable outcome, or whether it doesn't show any favorable outcome compared to preterm formula or not. So what we can conclude from this study is, obviously it can be given as a sole diet whenever mother's milk is not available in the initial preterm period till discharge, and that has a definite advantage in terms of prevention of NEC. Okay, so but slow weight gain and overall neurodevelopmental outcome, whether it will differ or not, again, it is very difficult to conclude with this trial because of all these issues.
And to take home the message that neurodevelopmental outcomes are again somewhat comparable, even if I give formula versus the PDHM is again not to be taken home because of the inadequacies sir has mentioned. And especially in a country like India, where many of our NSUs don't have such a access to PDHM. We're still across our country, not every city is having consistent supply of donor milk banks. So that should not tempt anyone to somewhat just indiscriminately or blindly kind of rely on preterm formula milk, because still mother's milk is the best. And uh, again, it should be equally balanced, whether we are having equal supply of PDHM, unless that also will again lead to loss of equipoise if everyone just keeps recommending mostly preterm formula milk, starts recommending it, because even then we should know that the guidelines still recommend preterm donor milk rather than preterm formula milk. If at all, they should be taken as a stimulus to establish more donor milk banks to be able to adequately study if we do want to conduct more RCTs. And that's why the last CASP checklist, does this study talk about the interventions? Does it give enough data to talk about does this study provide greater value to people in your care? So what resources are needed to introduce this intervention, taking into account the time and finance, skill development, and are we able to disinvest resources? So yes, this one take-home message can be that investment of resources should be directed more towards establishing milk banks to be able to compare both the interventions.
Yeah, definitely milk bank will be the future regarding feeding of ELBWs, because obviously mother's milk may not be sufficient in all babies, and lot of IVF trained pregnancies, triplets, all these sort of pregnancies are happening. So definitely there will be a need for safer alternative for mother's own milk. So that probably will be future will be a donor human milk, but the only issue will be how it will be regulated and how it will be available at a lower cost for all these women, especially those who come from a poor socioeconomic status. So affordability will be a main issue, and main concern will be this also should not go into the hands of commercialization, like how formula milk went into a commercialized space. So even we have read recent news that some of the companies which are promoting donor milk, they got relatively banned by the ministry, telling that the way they are collecting this milk and selling at a very high cost, this is not ethical. So that is the same concern which happened when formula milk started rampantly. They were sold rampantly. So we are also worried that whether PDHM will also go into such a commercialized space. So future will be obviously each hospital has to establish its own donor milk, which will be collected in a ethical way, and it will be sold to the uh, parents at an affordable rate. And the government has to go a long way in regulating these things. So probably time only will answer all these questions. Yeah, there are guidelines. Two questions are there in chat box. One is somebody has asked whether similar feeding guidelines are there for term baby.
There are studies where they have compared outcomes of breastfed infants versus formula-fed infants. I'll share that study in the group subsequently.
Basically, we are concerned about more about ELBWs because their neurodevelopmental impairment is a main issue, whereas they say and issues like NEC, all these things are a major issue in preterm compared to term babies. That's why there is not much discussion regarding which is superior. Whether to go for this milk or that milk in terms of term babies. Obviously, whenever mother's milk is available, that is superior, but uh, we don't have much issues when mother's milk is available in term babies because as such, they don't have much of this neurodevelopmental impairment.
Right.
Guidelines are there for human milk banking in India. Definitely is there, but to establish it is a very stringent guidelines. So that's why it is not very, you can see that only in specific centers, especially central institutes and few of the well-developed private centers alone are currently have established human milk bank. So ideal thing will be all hospitals, government, private, should be who are catering to level 3 care for ELBW should have a milk bank. But yes, it will take some time for it to be established.
Our center, as of now, does not have milk bank, but we're striving to develop one. We're striving regularly. But fortunately, we're in a city which does have access to around 3 to 4 milk banks. So we ensure that our extreme preterms do start receiving donor milk if mother's milk is not available. We go through all the lens to procure and store safely regularly. So that is the way forward, but it would be best to have our own center.
There are many ethical issues and cost issues, and very stringent monitoring is needed. Separate resources, staff is needed. So all these issues are there. That's why the future will be milk bank, but it will take some time for each hospital to establish their own milk bank. Any other questions also, you can ask directly or you can put it in the chat box.
We can conclude, sir, if there are no more questions.
Thank you all. Thank you, Ishita.
Thank you, Raja, sir. Thank you all.